Good afternoon. We are very pleased to have Dan Patel with us on our second of our ASDIN and NANT webinars. We're very pleased about this collaboration between these two organizations. And Dan's going to be talking about the care and cannulation of the surgically created AV fistula or AV graft. He's very well known in interventional nephrology, and one fun fact about him is that he loves to race cars, and that may be why he is located in Daytona Beach. So, Dan, over to you. Thank you so much for your presentation, and Dan will be taking questions at the end of his session.
All right. Thank you so much for having me. It's really a pleasure and an honor to speak to you guys today. I'm going to talk a little bit about the care and cannulation of AV accesses, and we're also going to talk a little bit about what the KDOKI life plan is for dialysis access. A little bit about myself. I'm an interventional nephrologist. I basically practice 100% dialysis access. I have an access center here in Daytona Beach, Florida, which is actually my hometown. I trained in Miami and then at Emory University in interventional nephrology. I'm pretty active with the ASDIN, which is the Society of Diagnostic and Interventional Nephrology. And basically every day, all I do is take care of dialysis access. So I have a real commitment to taking care of dialysis patients as a nephrologist, and furthermore, as an interventionalist. I've been active in publishing and teaching in the field as well. So I'm going to speak a little bit about the KDOKI care and cannulation guidelines. Now, we're not going to be able to teach you how to cannulate on a PowerPoint presentation here today, but I want to give you some tips and ideas and things that we think about when managing the AV access. So the KDOKI guidelines, basically, the goal is evidence-based vascular care. These are the kidney disease outcome and quality initiatives. You may be already familiar with this, but the idea is to use evidence to support better care of our patients and trying to standardize cannulation techniques and using a multidisciplinary team, including nurses and physicians, to really get the best outcomes for our patients. Part of this revolves around our own training and competency and seeing on how we're taking care of the patients for ourselves and looking back at feedback and how well things are going. And one of the things that we found is by monitoring the access, by intervening early enough, we can help prevent thrombosis. We can help keep accesses going longer. And that's really a bulk of my role as a physician working in dialysis access, is try to keep an access running and get the right access in and keep it working well for a long time. We've got multiple goals when we're cannulating the access. We want to preserve the vascular access. And one of the main things is trying to preserve more of a rope ladder technique than a kind of an area cannulation technique. We're going to talk a little bit about that. But we want to do what we can to kind of maintain the longevity of that working access. As we all know, that's what a patient needs to live, and we want to do everything we can to keep it working well. We want to minimize infection risk using safe aseptic techniques. We want to try to optimize the blood flow in the access with the ideal needle positioning, monitoring for any stenosis or clotting, looking at our physical exam signs and trying to know when to send the patient referral. Maybe they need an angioplasty and maybe something needs to be done to optimize the blood flow and help the access keep working well. And you want to try to standardize practices as much as we can. We know the dialysis units in general have a lot of turnover of staff. As much as we can to standardize practices and protocols, that kind of gives us the safest outcomes for our patients, so we can try to have facility-wide protocols to help things working in the best way. We want to keep the maintaining and training and learning. I'm a physician and I'm constantly learning every day, and the same should hold true for the staff and everybody in the units. You know, learning and constant feedback and getting improvement, that's what really gives our patients the best outcomes. And we want to keep things as comfortable for the patients. It's a scary thing when you tell the patient we're going to poke needles into your arm every other day. They see the accesses, they sometimes see the aneurysms, and they sometimes get a little frightened by the potential of this. Sometimes numbing creams, I don't love to use them, but we use them kind of in early settings when they're first using the access. We want the patients to kind of participate in their care, to kind of understand that, you know, to try to keep them as comfortable using an access as they can. That'll kind of keep their compliance with it and keep the accesses working well for all of us. Different cannulation methods are out there. Kind of the rope ladder technique, what we see in figure A here, is kind of our preferred kind of method, and that's kind of constantly moving around the needle sites. Now, the challenge is that if you have a high turnover of staff, or if the staff doesn't know the patient well, they may not always appreciate the importance of the rope ladder technique. Sometimes there's a rut of getting the patients on and off the machine as quickly as possible. And sometimes you fall in the trap of B, which is kind of the area puncture technique, where you basically kind of stick where the last person stuck. And that's going to work because it worked last time. It's quicker, it's easier. But what happens is over time, you can develop more aneurysms, you can develop more ulcerations. So we want to kind of rotate the needle sites as much as possible. We always instruct our home patients to try to do that. And we encourage that in the dialysis units as much as possible. Now, granted, we are sometimes limited. There's sometimes the vein is too deep to get a needle into safely, and it's not always easy to do the rope ladder technique. But that's what we like in the long term, that what gives us better outcomes and keeps the vein from kind of wearing out. The buttonhole technique is kind of coming in and out of favor. It was very popular when it first came out. It's a novel idea of kind of going the same track over and over, and kind of creating a track like an earring would, kind of going through the skin at the same angle. The challenges with buttonhole is, we started to see some infections with these things, especially when you have different kind of operators cannulating the access. If one nurse or tech goes in one angle, and then the next time somebody else goes in at a little bit of a different angle, it kind of ruins that buttonhole and it makes it more of a challenge. We do encourage it still for home dialysis patients or patients that self-cannulate, where you always have the same person cannulating the access, but it's a little bit more of a challenge in a setting when you have different people cannulating the access. And we've seen more problems with that in center, but out of the center, it's been a little bit better because it's usually the same consistent person cannulating. And this is kind of what we want to avoid, is when we have ulcerations here. And when the skin starts to get shiny, that's when it's starting to get thin. When we start to see scabs and things like that, this is a result of sticking the same areas over and over. Again, those might be the only sites that we can cannulate, and there's no other choice. But ideally, we do a rope ladder technique where we can cannulate in different spots, kind of avoid these areas of ulcerations. And these can be deadly. We look for thinning of the skin. Can you pull skin up over that ulcer? If you can't, and it's very thin, that's when you really need to have that patient seen with your interventionalist or your surgeon to maybe consider a revision of it. And it's inevitable for many of these. After many years, we've got some fistulas at 10 years plus, and the skin does start to wear out. So look for loss of color, look for when it's shiny, and look for, most importantly, when you can't pull or tent skin over it. That's a sign that maybe these things can be trouble. And every year, patients die when these explode in the middle of the night or something like that, because there's so much high blood flow under these things. We really want to be careful and minimize this as much as possible. For fistulas, what are our best practices for cannulation? And, your pre-cannulation inspection of the access, just looking with your eyes and your feeling of the access, looking for any redness, ulcerations like we just saw, any signs of infection. Your cannulation techniques. For a fistula, you want to generally use a tourniquet and let that vein dilate. If you don't use a tourniquet, that vein can collapse. It's a lot easier to cannulate a fistula with a tourniquet on it than with off of it. And that's really mainly for the fistulas. You want to insert the arterial needle towards the inflow and the venous on the outside. Flipping needles can be done, but we want to minimize that as much as we can. And then post-cannulation, you want to make sure that you're securing the needles nicely with tape. You don't want too much pressure on these fistulas. You generally don't need a lot of pressure. When we do interventions, we hold very light pressure for a few minutes. It's not the force of your pressure that stops the bleeding. It's the matter of sealing the hole and causing hemostasis and allowing the patient's own platelets and so forth, fibrin sheaths to clot off that site where they've stuck the needle. So not too much force. And then you want to teach the patients about signs of bleeding, signs of complications. You want to get them engaged in their own care, because when they're not in your dialysis unit and they're out and about in the world, they're living with that access, teaching them when things look troublesome, if they have bleeding, what to do and how to take care of it. It empowers the patients and it helps with the overall care overall. For graft cannulation, it's somewhat similar. You want to palpate the graft, look for any signs of infection, feel the thrills. If there's a decreased thrill or a very pulsatile, maybe there's a stenosis that needs some intervention. But examining the access is important. Your cannulation, generally you're using a 45-degree insertion angle. Sometimes it's a little different depending on the depth of the graft, but usually when they're pretty close to the skin surface, it's not too bad. You want to basically go until you see your flashback and secure your needles with the tape. Your complications, you want to rotate the needle sites, again, like we talked about with the rope ladder technique. Watch out for prolonged bleeding, which again, if there's prolonged bleeding, when you pull the needles out, many times that means there's a stenosis that's building up pressure, and sometimes treating that stenosis will relieve the pressure and help with the bleeding. And again, educate the patients on when to identify clotting. Can you still feel the buzz? Sometimes we give them a little plastic stethoscope to listen to their own access and they can help alert us when they hear something different or they feel something different. And sometimes the patients will call us at the access center and say, hey, my access is clotted, it's not working, before they even go to dialysis. That actually speeds up the quality of care for them, because they don't have to go to the unit, then be told it's not working, and then come back to us. We can minimize kind of the delays in care sometimes when the patient calls us directly and says, hey, I noticed this is a problem. Then we'll talk to the unit, we'll figure it out, and get the patient in for an intervention as needed. For central venous catheters, basically the care, you're all probably familiar with this, your basic dressing and exit site care, cleaning it well, changing the dressings. I prefer that the dressings are changed every treatment, but that's not always a protocol in every unit. Usually at least once a week, we want the dressings changed, and somebody looking at it, making sure there's no pus, making sure there's no purulence, no signs of infections. You want to flush the catheters before and after you use it. Most of the time we use heparin. Sometimes you can't use heparin. And then looking for complications of the catheter. Obviously, the most troublesome complication is an infection. And so we always worry about any septic issues or signs or anything like that. And then when the catheter is not working well, intervening for an exchange, that's usually in our hands, what we do when the catheter is not working well, and not waiting until it's not working completely. If it's not working well early, the chances are within a week it's going to stop completely. So getting the logistics in play to get the catheter exchanged, usually that's kind of our protocol around here. And then the goal is always that we're not using catheters for a long time. We want to transition to a permanent access if we can. Basically, infection control is really key for everything, and it's really taking the time to use the standard hygiene and aseptic techniques, washing hands, cleaning the access site, prepping it. We're poking needles into these accesses every other day. They are patients that are prone to infections, a lot of diabetics, a lot of infectious issues. So we want to keep this as sterile and clean as a process as we can. Properly inserting the needles and removing them, gentle pressure as we talked about. You don't usually need a lot of heavy force. And then again, monitoring for any complications, monitoring for any infections, referring the patients for help from the surgeons or the interventionalists whenever you see trouble, and then regularly following the patients. Every protocol, every place is different, but identifying when a patient needs an intervention and referring for an angioplasty or a procedure when they need to. Patient education and self-care. This is something that I think hasn't been focused a lot on in years past, and I think we're starting to recognize more and more. Empowering the patients a little bit more, having them check their own access, examining it themselves, telling them to be careful with the access. One of the things that we hear from the patients is they were told not to lift heavy things. And that's actually a little bit false. We want patients to actually stay active. When the patient has a fistula or an access in their arm, I want them lifting weights. I want them exercising. I want them, if you look at a bodybuilder and their veins are huge and popping out, that's kind of what we want for our patients. It helps with their self-conditioning. It helps with the access. What we don't want is something that squeezes against the arm. So I don't necessarily want my patient lifting a couch and having that couch leaning against the access and thrombosis it, but I do want them lifting weights. I do want them exercising. I do want them active and doing things. So we don't want to compress the arm with anything, but we want them active and moving. So in the initial post-op period after the access is made, a couple of weeks of letting it heal, but after that, full exercise, full weightlifting, whatever they want to do, keeping them active. It helps with the circulation. It helps with steel. We tell people with steel syndrome to pump a fist, pump a ball. Well, if you have them exercise their whole arm, that helps to mitigate some of those things for patients who can do all that. For bleeding, what do we do when if a patient, we want to tell them what to do if it bleeds? And usually the answer is to apply some pressure for at least 10 or 15 minutes. You don't need very hard pressure, enough to hold pressure to stop it. And then if it bleeds and they can't stop it, to get emergency help. I'm going to shift a little bit on the vein of bleeding, and I've got a picture of Coke bottles here. And in Europe, and especially in England and Wales, they know where I'm going at with this. But you may be asking yourself, why do I have a bunch of Coke bottles here? Well, Coca-Cola is full of phosphorus. We don't like our dialysis patients taking that. But what's more important is the end of the bottle. The bottle cap technique is something that's been used. It kind of got pioneered in England and Wales. And that irons Sumeru, I don't even know how to pronounce that. That's Welsh saying for basically the kidney Wales and England Kidney Foundation. And this is basically a bottle cap on a keychain. And they've done a good job in that part of the world of giving their patients all of these little keychains with bottle caps. And the question is why? Well, this is why. And this has actually been shown to save lives over there in Europe. It's been done a little bit here in the United States, but it's more prevalent there, especially in England and Wales. And basically, they give this patient a bottle cap on a keychain, so they always have it with them. And if they have a bleed from a fistula that they can't control with a few seconds of pressure, putting this bottle cap on there actually seems to solve a lot of the trouble. Gently putting this bottle cap on there until you get formation of a clot. And you can see here, you get a clot that forms underneath the bottle cap. This can be life-saving because that bottle cap goes over the access, over the aneurysm. This clot forms, and they just leave that bottle cap in place. They wrap it up with tape, and they call 911, 999 over there, but 911 for here in the United States. Here, when the patient comes to the hospital or the emergency room, basically that bottle cap has controlled the bleed. The surgeon can basically open up that area and then suture whatever they need to or revise whatever they need to. But this is done without losing the access. You're not completely putting a tourniquet on the fistula. You're not ruining the fistula. You've got that bottle cap. You get that protective clot that forms underneath the bottle cap, and it's been shown to save lives over there. It's something I've not seen in the United States that much, and I think it's really innovative, cheap, inexpensive way that they've really helped patients out over there on the other side of the pond. So in summary, for this part of the talk, vascular access, we want a standardized approach across the units to try to delineate protocols for the safest cannulation and care. Infection prevention and cannulation techniques are key. Monitoring the patients and early interventions when needed to keep the accesses going, and empowering the patients with the knowledge and self-care skills that they need that can help with our outcomes here. And this is our goal for all of our patients, that we eventually get a catheter out. Here's one of our patients. They had an access that took some time. We mark on the arm for the nurses where to cannulate. We've got this guy's catheter out. I covered his eyes for his privacy, but you can't miss his smile. And that's what we're going for. We're going for happy patients, happy staff, catheter out, reduces air infection risk, and we want the patients engaged in what they do. And this is a pleasure for all of us when we get an access that's not working well to start working well and working with the team to get a safe and good cannulation there. And so this is kind of an example of what we do in our setting, helping to mark things out where there's branch veins, where the vein is, where the fistula is. We tell patients when we mark their arms to take a picture of it with their own cell phones. That way, when the marks wash off, they can show their dialysis team, hey, this is where the needles are. I draw a little cartoon, a little diagram that I send out with the patients as well, so they can see what's going on. And again, it's empowering for the patients, for them to get involved in their own care. They've got pictures of it, and it helps the dialysis staff and the dialysis team. All right, I've got, there's a lot there. We'll save the questions for the end. I've kind of got another part of my talk here that I've been assigned to talk about, and this is kind of what we talk about, the life plan. And this kind of came about looking at the comprehensive care of the dialysis patient. One of the things that happened in the early days of access, everybody pretty much got a graft, and the graft was the thing that they all got, but they clotted over and over. We ran out of sites what to do. Then fistula first came. And fistula first was fantastic that we increased the number of fistulas, but then we kind of got to the pendulum swung too far where we were trying fistulas on everybody, and even patients where we didn't think a fistula would work. And you see patients with a multiple fistula attempts here and there and here and there. And sometimes we step back and we said, is that actually the best thing? Do some people need a graft? How do we delineate what's the best thing for the patients? And the key is kind of individualizing our care. And this is where the concept of the life plan came to, really a patient-centered approach, looking at long-term access planning to get better outcomes, because not one size fits all. For different patients, sometimes a graft is actually the best option, and recognizing that instead of having multiple failed fistulas to get to that graft, and the goal of trying to get that catheter out in a faster way. So the life plan is trying to tailor the care based on the patient, preserving the veins, preserving the accesses, avoiding, blood draws and things like that where the access arm is going to go. Trying to plan the access before they even get to the dialysis unit, which is challenging because that means the patient's already seeing a nephrologist. They're already in the system. They're already being closely monitored. Many of these patients just walk in the ER with the diagnosis of end-stage renal disease and they're started with a catheter. But if we can plan an access before then, that always helps. Minimizing our complications and, again, educating the patients helps quite a bit. And so the stages of the life plan, we look at CKD stages 1 through 3, and we're at that stage before any dialysis. We're trying to prevent progression of kidney disease on the nephrology side. And then stage 4, usually at that stage, you're really starting to plan the access. Are they going to do PD? Are we going to do an access in the arm? Is a preemptive transplant something that we can do from a funding standpoint, from a medical standpoint, try to get the balls in play there. When we get to stage 5 and when we're on dialysis, we really ideally have an access before we get there, but we know depending on your market and where you're working, sometimes those patients just don't get that care until they're on dialysis. And then once they're on dialysis, maintaining the access, keeping it working well. So the fistula, again, that's kind of our preferred option, but we need, they say 6 to 12 weeks. In reality, in our markets and most markets, it's 3 to 4 months to get a fistula generally up to speed. It depends on the quality of the access, the quality of the cannulators that you have in your market and so forth. But it usually takes a few months and maybe some interventions to get going. But they're the best thing. If it's a younger person, a healthier person, you're always trying to get a good fistula when the anatomy is favorable. Grafts are suitable for patients when the veins are too small. They do mature faster. So if we have some elderly patients or we have patients with multiple comorbidities where we're really worried about them being catheter dependent, sometimes a graft is the fastest way to get an access going. We do the mapping, we look at the quality of the veins, and we try to individualize and make the judgment. For this patient, it's a low likelihood that a fistula is going to work. Let's just do a graft and get the catheter out faster. Or we decide, well, maybe it's worth a try for a fistula, but let's not wait 6 months to see if it works. Let's put it in, wait 6 to 8 weeks, follow it with ultrasound, intervene when we need to, and decide soon if it's something viable that we can keep going rather than just staring at it for a year. We found that it really makes sense to kind of look at things earlier. And then with catheters, there are some patients that just rely on a catheter. Patients with significant low blood pressures that are on midodrine that can continue to clot their accesses. Some of them need catheters. Others have exhausted accesses, and catheters are the best options. And not every catheter is going to have sepsis and death. We have some patients that go many years and, don't tell them, but, there's some patients that have many years without problems with the catheter. It's just the nature of the beast. It is what it is. Some people get frequent infections, some don't. All things being equal, we're trying to get an access going, but some of them need a catheter, and it is feasible for some patients in the long term. When we're looking at patient-specific things, we're looking at their age and life expectancy, their overall vascular health. Is this somebody with multiple amputations where their arteries are poor all over and we're going to have a hard time with an access? Their other comorbidities, are they stable enough for a fistula creation? What's their cardiac status like? Do they have a heart that can pump enough to support an access flowing through it? Or is their heart disease really bad that a catheter might be best so there's no extra strain on the heart from a high flow fistula? If they're right-handed or left-handed, what do they like to do? If they're right-handed and they play the guitar, I really don't want to use an access in that right side. Try to do the other side as much as we can. Patient preference, trying to ask them and have them engaged in the conversation. For those that are, capable of making some of the decisions, it's always helpful to work with the patients and give them expectations. When we're making a fistula, we don't say it's 100% guaranteed it's going to work. We have multiple access options when we map our patients. If this doesn't work, we do this, we do that. Setting the patient up early on that it may not work the first time we try, but that doesn't mean you failed. It doesn't mean your surgeons failed. It's just the nature of vascular access. It can sometimes be tricky to get something working. And then decision-making, working with their team. The nephrologist should be involved. Their surgeons and interventionists should be involved. The nurses and staff, if you make an access, it's beautiful, but it's too deep and nobody can stick it. Well, guess what? Nobody's involved, the nurses and the staff in the quality of the access there. And so as a surgeon, as an interventionalist, we have to all be in tune of the end point is that it's easy for the access to be used by either the patient or the nurse, whoever's going to cannulate it, and getting everybody involved together. Likewise, you want good feedback. If the nurses are having trouble, there shouldn't be any hesitation to reach out to the surgeon or the interventionalist as the mediary, which is sometimes my role, is saying, hey, this is too deep. Let's elevate it. Let's change it. Let's do something, rather than a lot of finger pointing, which sometimes happens. The surgeon says, I think it's fine. The nurses don't know what they're doing. The nurses say, I can't stick this. The surgeon doesn't know what they're doing. Trying to get everybody on the same page with the ultimate goal of getting something working well for the patient. And I, as an interventionalist, I sometimes play that role. I'll get the feedback from the nurses in the unit. I'll get out my ultrasound, I'll measure the depth, and then I'll tell the surgeon, hey, this is too deep here, this is too shallow there, let's move this, they can't stick it, and so forth. And as an interventionalist, an interventional nephrologist, sometimes I step in the middle to try to get everybody on the same page. And it's different with different surgeons and different markets that you're working with. The preoperative evaluation, it's ultrasound vein mapping, but it's also this individualized care. Do we want to just make a graft in somebody and avoid the whole fistula route? That requires, I think, those involved in the decision-making process to kind of come up with the most tailored access for the patient. The timing of placement, access should always be placed yesterday. They're usually not placed in early enough, usually. Every now and then somebody's CKD and they go for a long time without needing dialysis. And sometimes we have to intervene on those accesses to keep them going so they're ready to go. Depends on the nature of the patient and what's going on. But we want the access placed well in advance of when they actually need it. Again, easier said than done. Depends on the patient's ability to follow up with their physician before they get in there. And then ongoing evaluation. Once it's in, how do you follow it up? Does your dialysis unit monitor it? Do they get ultrasound follow up with their interventionalist or their specialist? Every setting is different on how they follow up and access, but it all should start at the dialysis unit. They're the ones that are seeing the patients every other day. And then surveillance and maintenance strategies, again, it's variable. We want routine monitoring by the staff, monitoring by the patient, physical exam, your pressures, your clearances, and so forth. We utilize ultrasound in my setting to follow them up. We want to intervene when we can, avoid complications, hygiene, and so forth, all the basics. And then revision strategies. When an access is not going to work, what do we do? What's the decision making? When does that decision get made? Who's involved with it? And kind of going through those steps together to plan for revision when we need to. We want to minimize catheter use. Again, we know there's much higher hospitalizations, much higher infections. We want to reduce our catheters as much as we can. Alternative approaches, sometimes making another fistula, hero grafts, or another technique. There's other things we can do sometimes when they don't first start working. Trying to minimize the catheters as much as we can, but recognizing that there are some patients that we are going to need a catheter no matter what. So the key takeaways, basically, we want to plan access as early. Fistulas are really our gold standards, but they're not for everybody, and recognizing when they're not going to work for certain patients is key. We want really a patient-centered approach. We want to individualize care as much as we can. It's not just a template. It's not just a clinical pathway. You have to kind of step back, look and see what's best for the patient. I think monitoring and surveillance is key, following the access, the physical exam, training the staff on that. But again, that's hard when you have high staff turnover. Who's really monitoring the patient? Sometimes the interventionalists play a role in that in some settings, sometimes they don't. And then minimizing the catheters as much as we can. And the key is to get patients with good outcomes. Here's one of our patients here. They've got the catheter. This was a percutaneous endovascular fistula that we made. Again, it's got a mask, but there's a big smile on the face. We've got the one needle in the arm. We got one tube in the catheter. We started the process of maturing it. We did eventually get his catheter out, but we want to stay engaged in this process as the interventionalists, as the surgeons, as physicians. We want to be engaged in this feedback loop so we know that what we're doing is working. It's not just a procedure. It's actually this patient's lifeline. It's what keeps them alive. It's keeps them going. All of you on this call understand that and recognize that. But I think it's getting your physicians and your team and everybody involved in that patient's care to be on the same page. As an interventional nephrologist, this is all I do, so I'm really dedicated to it. But in some settings, you may have an interventionalist that does 20 other things and a surgeon that does 20 other things. And the focus is not always 100% there on the dialysis patient, and the interest is not always there. And so it's engaging those physicians to get on board with that, to kind of go back at looking at the patient and trying to get the best outcomes for the patient. All right, guys, that's all I got. Any questions at all?
You're welcome to unmute and put your video on if you want. And Dan, if you could stop sharing.
Okay.
We have several people. Patricia, you've been hanging on every word. Do you have any questions? I don't mean to put you on the spot. Okay. We had people streaming in as they got the reminder. Any options for the questions? Is there anything else, Dan, that you might get questions about? I thought the drawing on the arm was fantastic.
Yeah, we find that's really helpful. I draw little cartoons and send them out to the dialysis units. And so I send a diagram over whenever we do an intervention, whenever we do anything. Here's one I just did. I'll cover the patient's name. I don't know how well you can see that, but when we do an intervention, I don't know how well that's on the screen. There was somebody here that got infiltrated. And so Everything was fine with the access. They got infiltrated. I just draw a little diagram like that, but I drew directly on this patient's arm with a surgical marker. You can use a regular Sharpie as well. I tell the patient to take a picture of it, and then that way when they walk into dialysis, they have more than just a typed report telling them what happened. It's a little bit more of a straight shot. Ultrasound in the dialysis units is really important, but nobody does it. And I was part of a program. I was going to give one of the large dialysis organizations in my area 15 ultrasounds to all the different dialysis units that I work with. And that organization came back to me and basically denied it. And they said that they didn't think it was going to be cost effective and they didn't think it would help. That was a number of years ago. There's a couple studies that have come out of Emory University. They've done more ultrasound in the dialysis units. It's not too difficult and it's really helpful. If you can do an ultrasound, you'll see exactly where your needle should go. It's something I'm a big proponent of, but the larger dialysis organizations have been somewhat resistant to getting that in. Maybe things are changing a little bit now, but I find ultrasounds really helpful. And so in lieu of that, because I don't have ultrasound in my dialysis units, patients will sometimes come to me and I'll mark it on the arm and show them kind of what the ultrasound shows and show them exactly where to stick and where to go.
One of the things, topics that we've been talking about as we prepare for our annual conference in 3 weeks is, while we all understand that the nurses are responsible for educating the patients, it really falls to the dialysis technicians to emphasize and reinforce the education. With that in mind, if you could talk to every dialysis technician personally, what would you want them to reinforce?
It's tough. I really feel for the dialysis technicians because their jobs and their roles are constantly being stretched thinner and thinner. It's so much responsibility goes on these technicians, and some of them have very little training. Some of them have a few weeks of cannulation school, and then it's go off to the dialysis unit and take care of the sickest people in the whole healthcare system. It's broken. It shouldn't fall down to the technician to spend the time to teach and educate. It should fall up to the physicians, to the staff, to everybody else. It can't just fall on the technicians. It has to be broader and bigger than that. But fully recognizing the nephrologist is extremely busy. They're not there. The nurses are extremely busy and the technicians are extremely busy. It's difficult. And then you have a patient population where their ability to understand exactly what's going on is not always there. The level of education and knowledge is there. There are certainly gaps. And in my setting, actually, we have many patients that walk in for a vein mapping, and my vascular surgeons have the same experience, where the patient has no idea what is going on. They don't know why they're there. They don't know what a fistula is, what a graft is, what any of it is. And so it falls on me as an interventionalist and our surgeons many times to educate the patients what this is. And there are online resources, there are things, but time. And unfortunately, there's not a lot of time. If there's a way to somehow carve time in the patient's journey through dialysis to, step back. And there's some of that kidney education going into dialysis. So that is part of the slack that gets picked up to it. But again, these crash starts that, walk from the ER to the dialysis unit, to the vascular surgeon's office or the interventionalist's office, their heads are spinning and it's challenging to educate and teach them. But I will say that there are plenty of online resources. And even our older patients now, everybody's online. YouTube videos and so forth are great resources because you're not the limited amount of time that you have with the patient. Sometimes it's challenging to instruct them on what to do. I think at a minimum, teaching them to feel their own access, to feel for the thrill is important, to teach them what to do about when there's bleeding, because that could be life or death. Those are the things at a minimum that I would encourage education for the patients on. I know time is a constraint, but at a minimum, that could save somebody's life if they knew about the bottle cap or they knew about what to do if their access bleeds in the middle of the night. I think that's really a key important for patients with catheters to know that, they're feeling crummy and they've got fevers and chills, although they're being seen every other day in dialysis. for them to realize it's not just a regular cough and cold a lot of the times when you've got a catheter. Rather be safe than sorry. Rather get checked out sooner rather than later before a simple little catheter exit site infection turns into florid sepsis. And again, we have good follow-up with the patients with dialysis because you're seeing them every other day, but empowering the patients and educating them as much as we can. And then if you don't have the time, pointing them to the right resources online and YouTube. And there's one of my favorite online message boards was called I Hate Dialysis. I don't know if it's still around, but when I was first on, starting out, that was a message board started by dialysis patients where dialysis patients would educate themselves and share tips and share ideas. And they called it I Hate Dialysis, funny name, but actually a really valuable resource. And I think you'll find that every unit has some champion patients that actually can take the time and educate the other patients around them. They all talk, that they become a community, they all know each other and talk to each other. Empowering the patients a little bit on that end helps as well, if you can't carve enough time to educate them yourselves.
Patricia, are you going to ask a question? You're going to come off you've got to unmute yourself.
Come on, Patricia.
She's getting it.
All right.
On your phone, you've got to swipe a little bit to get it. Oh, Mary, thank you for sharing the link in the chat of IHateDialysis.com.
Look at this. I just opened this 493,000 post. Pretty impressive. And this is run by dialysis patients. I haven't looked in a while, but they talk about their journey. If you flip through this, it's what hurts and what doesn't hurt. I hate this. I hate that. It's an interesting community for our patients that can get online and interact and kind of go through areas. So
Patricia has unmuted. Go, Patricia.
Hello, how you doing? Where are you from?
So I work for Pennsylvania, and I used to work in the dialysis center. I worked in a dialysis center for years. I did dialysis for over 20 years. I'm a technician. Now I work in acutes. So now that I work in acutes, sometimes we see the same patients, but a lot of times we don't see the same patients. So we get in different patients all the time. So it's not like you're really going to get a chance to learn their access when they're coming to us. Like sometimes people come to us and they already have a problem with their access and we know nothing about it. So it's like you're sticking blind, really.
Yeah.
So do you have any suggestions for stuff like that? Because I know when you was talking about the outlining of the access and stuff like that, when I worked out in outpatient, I saw that a lot. But now that I work in acutes, we won't see that at all.
But one of the problems as interventionalists, most interventional nephrologists do not work in the hospitals. It's more cost efficient, more straightforward for us to work in outpatient settings. When you're in the hospital, there are resources everywhere. If you could find a champion to get you an ultrasound machine, and it's really not hard, you just get the probe and start working with it. If you take an ultrasound machine, you'll see exactly where the vein is. You'll see exactly where the outline of it is. You just take a little gel, you throw it on the fistula and the graft, and you can see where it goes. You may need a radiology tech or radiology department to loan you an ultrasound and show you where it goes. It depends on your hospital system, how willing they are to help you and empower you with that. But that's something that's massive. I mean, if you can get an ultrasound, you'll know there's no more guesswork. Because otherwise, it's a patient you've never seen before and you're guessing. And your best guess is usually going to do the area cannulation where you stuck where the last person stuck. And you may see them 1 or 2 treatments and may not see them again. They may be in an ICU for 3 months. And so you'll get to know that one that's been there for a long time. Otherwise, it's reasonable. If you're going to only use it here and there to stick where the last person stuck, that's really your best guess. It's challenging. Sometimes patients that have been in the outpatient setting, if they've been in my area, they may have a photo on their arm of their arm on their cell phone, and sometimes they'll tell you, don't stick here, stick here. Sometimes the patient can point that out, but you don't always get that interaction. And so Ultrasound is your secret sauce. If you can somehow get that, that would empower you to be able to stick this a little bit easier. And you need some sort of buy-in from your radiology department, maybe your radiology techs. And your selling point maybe to your administration is that it'll help us cannulate these patients safely. It'll help us minimize catheters, and it may reduce the time that they're in the hospital. If you can't cannulate and access, your next step is to ask for a catheter. So if you tell the administration, and I don't know, every administration is different, that because they think in dollars and cents. And so if you can make the financial argument, hey, we've got an ultrasound, you have techs, can you just come down and help us with how to stick this? Maybe we can avoid a catheter, and maybe we can get to using it. And it's tricky for those patients too, because they may go to the outpatient unit where everybody knows that access inside and out, and then you're forced to deal with whatever you have to deal with in the hospital.
Find that helpful, Patricia?
Yes,
Good.
I think it will work in some situations, but I just don't know how agreeable the hospitals are. So I would
Yeah.
have to find out.
That's why I don't work in a hospital. So I could kind of make the situation how I want. But you got to deal with the resources you have. You got to deal with what's at play. There may be some pushback, but it doesn't hurt to ask. And it's really not too complex once you start doing it.
Yeah. Yeah, they might think because it is cost effective that it might not work because we're not seeing these people all the time. So
Yeah,
I'm
but when
not
you need
sure,
it, you
but
need it. Yeah, when you need
yeah,
it, you
but I'm gonna put
absolutely
it
need
out there.
it. Yeah, give it a shot. See what they say. If they want to talk to me, I'd be happy to talk to them. They probably don't want to talk to me, but if they do, I'm here.
Okay, thank you.
Mhm.
Yeah, that's the thing about doing what you do. I know patients aren't necessarily happy to be seeing you in the first place, but they're glad when they leave.
Well, it's interesting. We, develop a pretty good relationship with these patients. And so we get to know them. Access issues are frequent and recurrent, and it's actually not so bad. In the outpatient setting, we try to make it as comfortable and convenient for them as possible. We know them, my nurses know them, my front office knows them. It's generally a pretty good experience. Nobody likes to have a clotted access, but they recognize that at least when they're coming to an access center where the whole team's dedication is to that access and nothing else. They walk into an environment. Our goal is to make it an environment where they feel comfortable, where they feel satisfied. And the outcomes aren't great. I'm not going to be able to open every access. Maybe I have to put a catheter in, maybe I have to do something. But at least as a physician, it's kind of why you wake up in the morning. You try to get that connection with the patient and try to get them the best outcomes that you can. And I think most of our patients appreciate that. The dialysis patients, as you know, they're generally a pretty appreciative group. They all realize they're not going to be alive without dialysis, and they're not going to be alive without a good functioning access. So they tend to appreciate all of our efforts and what we do and everything we can do to keep them out of the hospital, at least in my setting.
Okay. Let's see. I think that you've done a heroic overview of the situation. Can you tell us, digging back into your history with the patients, what was kind of the most outrageous case that came to you, akin to like the little boy going to the ER with beans up his nose? I mean, that kind of thing. Do you have anything similar to that?
Well, I think most accidents, there's a lot of times where the access is working perfectly fine. It's just they're not being cannulated correctly. And that's not a big deal. It's not a problem for us. There's nothing that's really a waste of our time because everybody coming to us has a problem and something that needs to be fixed. What I get disappointed at is when I don't see as much passion or interest in dialysis access as I do. And obviously, I'm on the spectrum of being all in, like this is what I do, this is what I love. But it's frustrating when we see that lack of compassion or dedication to AV access care. Vascular surgeons are not always interested in doing these cases. They don't pay a lot. They're not very interesting. Sometimes people do fellowship and training and do 1 or 2 fistulas and then go out to private practice. They haven't done that much. There's more money doing other things in vascular surgery. And these are complex patients with a lot of comorbidities. There's not always a comfort level of taking care of a dialysis patient and all their other medical issues. I find that somewhat discouraging. I called a vascular surgeon once for a patient that had an issue that I needed a surgical revision for. And he said, I stopped doing dialysis access and it was the best thing ever for my career. It's like no more calls in the middle of the night. My weekends are free. Financially, things are better. Like he was the happiest guy in the world that he stopped taking care of dialysis patients and dialysis access. And I see that every now and then. It's really discouraging. It's kind of why I fight to do what I do. And you see the same sort of thing in general nephrology. General nephrology has very little popularity anymore. And I don't know if it's steamrolled into nursing and care across the spectrum. We're being forced to do more and more for less and less money. The times constraints are significant for dialysis in general. If you're open 6 days a week, the nurses and staff have to work on late days and weekends and things like that. So the passion for nephrology, for dialysis and end-stage kidney disease management is not there. There's just not that much of it. It provides opportunities for those of us who are interested, but it's really discouraging to see on a global perspective that not everybody's fighting to become a nephrologist that's in medical school. They don't really want to do it that much. And I think some of that is trickling into the passion and care for dialysis care in the outpatient setting. And so it's more of a, it's not funny, it's discouraging, but it forces those of us that are in it, I think, to stand up even more for our patients and stand up even more for the care that we're providing and what we're doing for them. And our goal is to make it easier for those that are not as interested in this. You know, my goal as an interventionalist is try to make my surgeons' lives a little bit easier, to try to make things a little bit more straightforward for them. And I think all of us working together as a team, that's the only way that this kind of happens. So it's disheartening to see the lack of passion. The days in my market of 30-year dialysis nurses, they've kind of all retired, and the new generation is not sticking around in my market with dialysis as much as they used to. And I think there's factors at play. There's money, there's time constraints, there's pressures from the large dialysis organizations and so forth that make the work environment challenging. And so I think it's up to all of us to try to stand up for our patients and try to keep things as positive and as patient-oriented as we can.
I think that's a great message to end this. And I want to thank you, Dan, for a really engaging presentation. I was fascinated by it, but I only work with dialysis technicians. I don't play one in real life. And I must say, if you want to see passion, we would love to have you speak at the Dialysis Technician Connection, which is going to be 3 weeks from today. Your colleagues, Rick Mishler and Nege Mala, are going to be there, and we have the best and the brightest technicians that are chosen by their employers to come be with 400 or 500 other technicians who really do have great passion for their job. So if you're ever in a position that you want your faith renewed in the passion for dialysis, we're the place to come to.
Amen. I'd love that. No, that sounds great. You know, it sounds like a really dedicated organization, and you know the struggles that I'm talking about. If you can, you know, spread your seeds of magic across, I think that would go, you know, a big way to kind of empowering our dialysis centers, our nurses, our techs, and everybody taking care of these patients.